We'll now go straight into our second segment, which is focused on connective tissue disorders. We take great pleasure in welcoming Professor Dr. Tahir Masood, a distinguished pediatrician and principal of Rashid Latif Medical College, alongside Dr. Samia Naz, Associate Professor of Pediatrics at the Children's Hospital. May I now request our esteemed chairs to kindly come forward and lead this session.
I just want to add that actually Professor Tahir Masood was the first pediatrician as head of department in pediatrics in Children's Hospital who started pediatric rheumatology in a pediatric setting. So just as we started pediatric rheumatology in an adult rheumatology setting, they have been pioneers of starting that in a pediatric setting, and Dr. Samia is doing actually dedicated pediatric rheumatology. So over to you.
Our next speaker for the short pediatrics course is Dr. Tae-Kai Liang, Assistant Professor at Duke NUS Medical School and Consultant in Rheumatology and Immunology at KK Women's and Children's Hospital, Singapore. Today, he will be presenting on childhood SLE and monogenic lupus. Please join me in welcoming him to the stage.
All right, a very good afternoon. Thank you for the kind introduction, and thank you to the organizing committee for the invitation to give this talk. So I'll be talking about childhood onset SLE as well as monogenic lupus. Before I dive into this topic, I'll first like to read an excerpt from a patient's story written by a third-year public health major student. On a night in 2015 when I was 12, I woke up with pain radiating through my joints. I could feel the sores in my mouth getting worse by the minute, and my ankles were swollen. The next day, my parents brought me to the hospital. After getting settled inside, the doctor on call said that they didn't know what was wrong with me, but they were doing numerous tests. I was a typical kid, energetic, active, and carefree until these troubling symptoms began to change my life. I had constant joint pain, butterfly rashes on my cheeks, and extreme fatigue. It wasn't until I had spent 2 weeks in this hospital and during countless tests that the doctors confirmed what was wrong. I had lupus. As a young boy with no family history of any autoimmune diseases, my diagnosis was at first overlooked. The absence of clarity from my medical team was overwhelming. It took weeks to pinpoint that I had lupus, and during that time, I was subjected to a multitude of tests that could have been avoided had there been better awareness of my disease. On week 2 of my stay after a biopsy, I was told that I had kidney nephritis. While I was fortunate to have access to a hospital that eventually identified my condition, patients without access to a rheumatologist or physician experienced with lupus can just as easily receive incorrect treatments and care. Now, I'm sure many of you may be familiar with lupus in one way or another, but this story really highlights the challenge in diagnosis and management of lupus in a child, which is less common than in adults. So over the next 20 minutes or so, after giving an overview of childhood onset SLE, I'll be highlighting unique considerations in childhood onset SLE and when this may be more in the form of monogenic SLE. So childhood onset SLE is a chronic autoimmune multi-system inflammatory disease, and we say it is childhood onset when the onset is less than 18 years of age. Childhood onset SLE takes about 15 to 20% of all SLE patients, but as pediatricians, we always like to stress that children are not young adults, and there are a lot of differences between childhood onset SLE as well as adult onset SLE. First, in terms of epidemiology, it really depends on which geographic location you come from. For example, in the white population, the prevalence range about 3.3 to 8.8 per 100,000 children, whereas it is more common in the Asian population. For example, in Singapore, this number goes up to 14.2 per 100,000 children. Asian patients are also more prone to serious clinical manifestations, so the genetic as well as ethnic differences really contribute a lot to the heterogeneity of this condition. The median age of onset is about between 11 to 12 years old, and if you notice the female to male ratio, there is a lesser female predilection in childhood onset SLE compared to adults. In the 13 to 18 years age group, it is about 15:1, and as the age group decreases, you will notice that there is less and less female predilection. So one of the common myths is that a typical SLE patient is a teenage girl, and this is obviously not true. SLE can happen in prepubertal age. SLE is not so common in less than 5 years old, and when it does, you need to think about monogenic lupus. And do not dismiss a boy with lupus-like features in a child because of a lesser female predilection. Now, coming to the pathogenesis, we know SLE is multifactorial. There are genetic, epigenetic, hormonal, as well as environmental predisposing factors. There is an interplay between the innate immune system as well as the adaptive immune system. And the key players are type 1 interferons along with autoreactive T and B lymphocytes, as well as autoantibody production. But I want to highlight some key concepts over here. First is genetic predisposition. The younger the disease onset, the higher the chance of genetic being the cause of the SLE in the form of monogenic SLE. Next, because a key characteristic of SLE is autoantibody production, you need to try and find these autoantibodies during the workup. And a lot of the features are actually due to immune complex formation. But because of the presence of type 1 interferon, a lot of the features can also be attributed to type 1 interferonopathy and may not be due to immune complex formation. So what are the differences in terms of clinical features between childhood onset SLE as well as adult onset SLE? So this was a meta-analysis that was published in 2017 that looks at over 10,000 lupus patients. And the authors found that adult onset SLE had more pulmonary involvement, pleuritis, as well as Raynaud's phenomenon, whereas childhood onset SLE had more neurological, renal, hematological involvement, more constitutional symptoms, as well as more mucocutaneous manifestations. So some of the, I know that some pediatricians as well as family physicians may not be so familiar with the clinical features. So I'd like to show some pictures of clinical features that you can find in childhood onset SLE. So this is a classical malar rash, okay, which typically spares the nasolabial fold and it must cross the nasal bridge. But sometimes it may not be so diffusely erythematous. It can appear more vasculitic. As long as it is in the malar distribution, then we still call it a malar rash. These are discoid rashes that tend to happen in the photosensitive areas and it can scar. So recognition of these rashes is very important in order not to have severe cosmetic consequences. The discoid rash can also be found on the ear pinnas as well as on the scalp, and it can cause scarring alopecia. Now, if you have a dermatoscope, it is very interesting to look under the microscope, under the dermatoscope, features of discoid rashes. So on the left is a schematic diagram of some of the key characteristics that you can find in a discoid rash. So you get follicular plugging, follicular red dots, perifollicular whitish halo, linear blood vessels, pigmentation, rosettes, and starburst patterns. And on the right, you can see that there is an actual picture of a discoid rash under the dermatoscope with a lot of follicular plugging, perifollicular whitish halo, as well as the background of very abnormal looking blood vessels. Now, oral ulcer is interesting in lupus because it tends to happen on the hard palate and is painless. So a lot of times patients may not know that they have these oral ulcers. It is important to look out for them during physical examination. And it is also important to look at the extremities because of the presence of vasculitic rash. So there are a lot of different skin manifestations ranging from vasculitic rash, malar rash, photosensitivity, discoid rash, panniculitis, and tumid lupus erythematosus where they get these annular looking rash, as well as tubular lupus on the left picture. Now, even among the cohort of childhood onset SLE, there's a lot of heterogeneity. So this was a study that compared pre-pubertal childhood onset SLE to the peripubertal as well as the post-pubertal age group. And the authors found that in the pre-pubertal age group, there is a lot more cutaneous, renal, as well as pulmonary involvement, and less hematologic involvement compared to the peripubertal as well as post-pubertal age group. The pre-pubertal age group also had greater severity and more delayed diagnosis, and all these will result in poorer prognosis. Now, in terms of classification criteria, there's no specific classification criteria for childhood onset SLE. We still use the same classification criteria for the adult SLE, the ACR 1997 criteria, the SLIC 2012, as well as the EULAR ACR 2019 criteria, which has a weightage of points given to it. Now, one of the common questions is, so what classification criteria do we use? And I will always answer and say that in a classical lupus patient, it really doesn't matter which classification criteria you use. So when we look at our own local cohort of childhood onset SLE patients, you will find that almost all of them, 85% of them, will fulfill all three criteria. When we look at the diagnostic performance for individual classification criteria, the ACR 1997 criteria has the highest specificity, whereas the SLIC 2012 criteria has the highest sensitivity. So classification criteria are usually used to recruit homogeneous group of patients into research projects. And for that purpose, specificity is important. And therefore, I think it is good to use the ACR 1997 criteria for research purpose. But I also know, even though it's not intended for this purpose, a lot of physicians would use classification criteria to help guide diagnosis and see whether the patients could have potential lupus or not. And for that purpose, sensitivity is more important. If you use the ACR 1997 criteria, you will miss out some potential lupus patient. Okay, so the findings actually mirrors a meta-analysis that was performed in 2022, again, looking at the performance of different classification criteria. And again, the SLIC criteria had the highest specificity, whereas the ACR criteria has a higher sensitivity. So I'd like to highlight two different cases. For example, in case 1, a patient with bilateral pedal edema, renal biopsy showed lupus nephritis. Patient is ANA positive and a positive anti-double-stranded titer. And this patient will not fulfill the ACR criteria because of only one systemic involvement as well as 2 immunologic features. Similarly, in another case, this patient had fever, hemolytic anemia, malar rash, DCT is positive, ANA is positive, but the double-stranded titer is negative. Again, this patient would not fulfill the ACR 1997 criteria because of only 2 system involvement as well as 1 immunologic features. But all of us would agree that these 2 patients probably smell like a lupus. So some of the key consideration when using classification criteria in childhood onset SLE: number 1, some children may present with early incomplete features that may not be captured using the 1997 ACR criteria. The renal and hematologic disease may also precede skin manifestation, and because the ACR 1997 criteria gives quite high weightage to skin, so they may not fulfill that. And also fever is not included in the criteria, and a lot of children actually present with constitutional symptoms as well as fever. If you do suspect a patient with lupus, then these are the blood tests and workup that I would do. A full blood count to look for cytopenias, renal panel, liver function test, and inflammatory markers, because typically in lupus, you will get a low CRP, whereas your ESR is high. Urine analysis and urine protein creatinine ratio is really important because of a high renal involvement. And immunologic workup, you would want to find evidence of antibodies like ENA, double-stranded DNA, and ENA profile. Skin biopsy may not be necessary in a very classical picture, but if there is any doubt in diagnosis, the skin biopsy is sometimes helpful. But for any renal involvement, the lupus, for lupus nephritis, the renal biopsy is mandatory because it helps guide the management. So just a word on anti-nuclear antibody. This was a study that was done to look at the distribution of ANA titers among healthy individuals according to age. And I'd like to just highlight a few findings. Number 1, up to 13% of the patients can have a positive anti-nuclear antibody even among healthy individuals, and most of these tend to be of low titers. As opposed to the distribution of anti-nuclear antibody titers in children with autoimmune rheumatic disease, firstly, about 63% of them may be negative for anti-nuclear antibody. And even if you look at the lupus cohort on its own, there's a substantial number that may have negative ANA. But if they are positive for ANA, then these tend to be of a higher titers. So again, this was another study that again showed a very high positive predictive value in a high titer anti-nuclear antibody. So ANA is really not an autoimmune screen. A positive as ANA does not mean that the patient has got lupus. The positive predictive value really increases when the clinical index of suspicion is high, and not all SLE are ANA positive. So just to share a bit of our Singapore experience, in terms of our cohort of patients, about 80% of them are females. In terms of racial distribution, it is a bit different from our national racial distribution, with more Malays compared to the national racial distribution. The median age at diagnosis is about 12 years old, with a mean age of onset at 11.5 years old. And if you look at the clinical manifestations of childhood onset SLE in Singapore, about 50% of them will present with mucocutaneous features, 45% of them has renal disorder, and 80% of them has got hematologic disorders. Almost all our patients are ANA positive, and we have a very high double-stranded DNA titer, as opposed to some centers in US as well as in Europe. Antiphospholipid antibodies are also not uncommon in Singapore, about 40%, whereas in Pakistan is about 12%. So this was a study that was published to look at Pakistan experience in childhood onset SLE. That the mean age at diagnosis is about 10 years old, and a female 85%, but the female to male ratio is only about 6:1. There is a positive family history of lupus in about 6% of the patient. Majority of the patients present with nephritis, hematologic manifestation, as well as skin manifestation, whereas neurological, photosensitivity, and vasculitis are less common in the childhood onset SLE. Okay, just a word on lupus nephritis because it is common in childhood onset SLE. The pathogenesis is really complex, contributed by complement activation, immune complex deposition, and direct podocyte injury from cytokines. This was a study to look at long-term follow-up data on kidney and patient survivals in childhood onset lupus nephritis. And you can see that up to 30% of them may have kidney failure. But fortunately, if you look at the newer publication, the rates of kidney failure is lesser. And I think this is encouraging to say that with improvement in terms of treatment, technically less and less patients should get kidney failure. Most of our patients with lupus nephritis, almost all of them will present with proteinuria followed by hematuria, and about 70% of them will present as a nephrotic range proteinuria. For renal biopsy, a lot of them has got class 4 lupus nephritis, followed by a combination of class 3 and 4 with class 5. But again, of course, there's some bias because we do not routinely biopsy all lupus patients, so there is an underrepresentation of class 1 and 2, which may be asymptomatic. So the principles of management is really to have induction therapy, and you want to achieve a target of low disease activity or remission, followed by maintenance therapy. But some of the key considerations in childhood onset SLE is that childhood onset SLE tends to run a more aggressive course, so the treatment must be able to match up to this. There is, however, impact on growth and development in some of the drugs that we are using, and because of various sizes of children, the drug dosing is also one of the concerns in childhood onset SLE. We borrow a lot of the concepts from the adult management. This is the 2023 EULAR recommendation as well as the 2025 ACR recommendation. I'll just highlight some of the key important findings. Both recommendation would encourage a multidisciplinary approach and assess disease activity with well-validated tools. They also highlight the importance of non-pharmacological therapies, and you want to aim at remission or low disease activity. For steroid, both recommendations actually say to reduce the maintenance dose to less than or equal to 5 mg per day, and when possible, withdraw the steroids or slow taper towards 0. Although in childhood onset SLE, this may not always be possible because of the more aggressive nature. Hydroxychloroquine is recommended for all patients, and in fact, the ACR 2025 recommendation guideline says to continue it indefinitely. Skin manifestation, other than the usual conventional DMARD, methotrexate can play a role. Similarly, in arthritis, methotrexate may play a role, and the role of methotrexate may not be really that helpful in other manifestations. For hematologic, there is also a possibility of using IVIG that is recommended in both guidelines. And for lupus nephritis, this is the KDIGO adult guidelines for lupus nephritis. For class 3 or 4, with or without class 5 lupus nephritis, you want to start off with glucocorticoid with or without pulse methylprednisolone, depending on the severity. And patients may receive either of the 4 different kinds of treatment arms. The first is a combination of calcineurin inhibitors together with mycophenolic acid analogs. The second is just a pure mycophenolic acid analog. And the third would be cyclophosphamide, and last would be the belimumab. Okay, so what about clinical practice guidelines that are specific for childhood onset SLE? This is published by the Japanese doctors, and it's mostly used for their internal as a clinical practice guideline. But I think they are trying to convert this into a recommendation statement, and the manuscript will probably be published later this year. So in this clinical practice guideline, they say that the first step is for diagnostic workup, including also antibodies. The second step is to evaluate organ damage and disease activity. And the third step is to do baseline condition like bone mineral density, ophthalmic screening, growth, as well as echocardiogram. They classify the lupus patient into high risk, middle risk, and low risk. For the low risk and middle risk patients, you just need steroid as induction therapy, then followed by maintenance therapy with either azathioprine or mesorabine. Whereas for the high risk patient, induction therapy includes cyclophosphamide or MMF, followed by maintenance therapy with conventional DMARDs. Okay, so I mentioned some of these medications already, but other than what I've mentioned, I also want to highlight the use of organ-specific medications, for example, topicals and skin manifestation, renal protective medication for lupus nephritis, and don't forget the vitamin supplementation. Once you treat a patient, you want to achieve a treatment goal, and similar to adult, we also have treatment goals of low disease activity, remission, as well as remission of steroids. The only difference is because of the size of children, then therefore we have a weight-based prednisolone aim. In CLLDAS, we want to aim prednisolone less than or equals to 0.15 milligrams per kg per day, or a maximum of 7.5 milligrams per day. In remission, we want the prednisolone to be less than or equals to 0.1 milligram per kg per day, or a maximum of 5 milligram per day. And of course, for remission of steroids, then there should not be any steroids. Other than the medical management, I think as pediatricians, it is also important to take care of the holistic health with some protection measures, infection controls, encourage physical activities for better bone health, vaccinations to prevent infections, as well as screening for complications like eye screening, bone health, as well as growth. But really, just be aware that a lot of complications can result as use of medication, with a lot of patients may have glucocorticoid toxicity, as well as high risk of infertility in some of the medications that we use, like cyclophosphamide. One of the things that we may not do so well is really to assess the cardiovascular health. This was a study to look at the cardiovascular risk factors for childhood onset SLE patients that have gone on to adulthood. And they look at the risk of stroke as well as AMI, and you can see that the median age is far lesser than what we would expect in the healthy population. So really, I think as pediatricians, we really should encourage good physical activity and just be a bit more aware of the physical and cardiovascular health for our patients. Other than physical health, of course, there is also emphasis on psychosocial development, as patients may miss schools. Patients are also affected in terms of change in body images from the steroids. A lot of these children who are in puberty, they may have medication non-adherence. And really, there is also a huge impact on family members as the disease burden extends to those that are taking care of children with childhood onset SLE. So lastly, I want to talk about monogenic lupus. It is different from systemic lupus. It is a rare form of lupus. It is due to a specific single gene variant. And because of that single gene mutation, there's usually an early onset disease cause as well as a more severe clinical phenotype. So in terms of the pathogenesis, I mean, this was a very busy slide, but it is due to single gene mutation in any of this pathway. There are three main mechanisms. One, it results in defective clearance of nucleic acid as well as immune complexes. So like, for example, complement deficiency. Two, whether there's dysregulated lymphocyte tolerance. And three, whether there's intrinsic activation of type 1 interferons. So these are the genes that have been published so far that has been related to monogenic lupus. But once you identify a gene, you will want to see whether it fits any of the biologically plausible pathways as what I have mentioned just now, whether it is due to complement defect, whether there is an issue in terms of nucleic acid sensing or nucleic acid destruction, whether it is a problem with interferon 1 production and interferon 1 signaling, and whether it is due to immune tolerance. So this was a study that was done by Dr. Sulaiman in Saudi Arabia to look at monogenic lupus and comparing it to sporadic lupus patient, and what are the differences between the two. So they found that monogenic lupus, there is less female predominance, there's a higher rate of consanguinity, more family history, as well as younger age of onset. In terms of clinical features, they found that patients with monogenic lupus compared to sporadic childhood lupus has more failure to thrive, recurrent infection, and more atypical presentation like GI involvement, ocular involvement, and nail changes, as well as low C1q. In terms of treatment outcome, most of the monogenic lupus patient, similar to lupus patient, they will need some of these conventional DMARD, but a lot more monogenic lupus patients actually use anti-CD20 therapy, as well as JAK inhibitors. And unfortunately, monogenic lupus also tend to not do so well with higher mortality risk compared to the sporadic systemic lupus. So when do you suspect monogenic lupus? When the patient presents at a very young age, especially less than 5 years old, when there is consanguinity or a strong family history, when there's recurrent infections, failure to thrive, or atypical presentations and refractory disease. Again, the same group actually came up with a proposed clinical tool to identify high-risk patients for monogenic lupus. This is a pilot study that has not been validated in other cohorts. But what they found was these top 10 items that constitute the proposed clinical score that is associated with monogenic lupus. And each item is assigned a weight of 1 point. Early disease onset less than 5 years old, consanguinity, family history of lupus, elevated ANA, pancytopenia, failure to thrive, cutaneous lesions, imaging changes, low C1q, and recurrent infections. So comparing monogenic lupus, the presence of elevated ANA really differentiated from other systemic autoinflammatory disease, and the presence of an early age of onset consanguinity as well as family history really differentiated from sporadic lupus as well as other connective tissue disease like JDM. So they said that a score of 3, more than 3, is predictive of diagnosing monogenic lupus with really high sensitivity and specificity, but of course, this will require validation in other cohorts. So what's the implication of having a patient with monogenic lupus? First, monogenic lupus can only be diagnosed if you have the genetic testing. Okay, so if it's available, you should send off the genetic test and then see whether it matches one of those biologically plausible pathways. Two, there is increased role of biologics such as JAK inhibitors in monogenic lupus, whereas the sporadic systemic lupus tend to respond quite well to certain conventional DMARDs. And there are also additional therapeutic options. For example, if this is due to a complement deficiency, then fresh frozen plasma may be one of the additional therapeutic options. And lastly, it is also important for family planning as well as counseling. So some of the take-home messages: children are not small adults. This childhood onset SLE tend to run a more aggressive course, and there are differences in terms of clinical features. There's really a lot of heterogeneity within the childhood onset SLE cohort, especially in the pre-pubertal age group, and also contributed by ethnic and gender differences. Antibody testing is really only useful when you suspect a patient with SLE. It is not the answer to whether the patient has got SLE or not. And you really need to balance disease control with damage accrual from disease as well as treatment. And lastly, you need to think about monogenic lupus in a very young child with severe or refractory disease, as well as a strong family history or history of consanguinity. Okay, with that, thank you, and I'll take questions later.
Thank you, Dr. Liang. That was a very informative speech. We are pleased to welcome back Professor Tash Arkachaisri, who will now be presenting on juvenile dermatomyositis. Please join me in warmly welcoming him to the stage.
As you can see, I'm almost 60 here, and then they use me quite interestingly. Okay, I will try not to. Okay, I need to go on. Okay, nothing to disclose. And then this is the outline that we're going to go through. It's like any other connective tissue disease or rheumatic disease anyway. Okay, let's look at the characteristic. So we always think that Asia Pacific has less JDM compared to Caucasian population in the West. But when you look at the number, that may not be true. In Singapore itself, last week I just tried to look at it again. It's still 0.2 to 0.3 per 100 case of the incident, which is on par with some of the country. The only thing that less would be in the US. They see almost 1 per 100 case. Okay, and the prevalence is about 2 to 3. Okay, so we do see about 6 to 8 per year a new case. I think Pakistan probably around the same number. Okay, and we know that is the most common idiopathic inflammatory myopathy. Okay, I want to show you one of them is orbital myositis. We see it sporadically, maybe every 5 years we may see 1 or 2, and then the treatment may not be that different, and response to treatment is the same, quite good. Okay, now the immunopathogenesis. I hate this BC slide. I just got highlight because nowadays you need to know immunopathogenesis because we have targeted treatment when the conventional synthetic DMARD is not working well. Okay, the first one is from the tissue or from the blood circulation. The type 1 interferon signaling is thought to be the central role in the pathogenic change in various tissue in the JDM. Okay. Before that, it's actually, everyone knows, is the environmental factor, especially UV ray, and then certain viral infection together with susceptible genetics. And the genetics we are talking about is HLA-DRB1, which you don't need to remember, but these two actually come more and more. Okay. And then another thing would be the circulating inflammatory mediator like galectin-9 and CXCL10 actually fluctuate with disease activity. When I was in the US, we used serum neopterin to follow the muscle activity. We used von Willebrand factor, von Willebrand factor, antigen level to follow the vasculitis or vasculopathy part, which is not available here in Asia Pacific. But this thing is, both of them are interferon-related protein anyway, and lately for the past 5 years it's come quite strongly. So we may see in commercial. Okay, so that's the only thing I need you to know about immunopathogenesis. Number 1 is type 1 interferon. Number 2, we may have biomarkers. that help us. Now go to clinical manifestation. As compared to the adults, since we have adult colleagues here, JDM is the most common one that we see. We don't see any other types as compared to the adult dermatomyositis. And then for us, we have a lot of skin manifestation as compared to the adult. Okay, but also we see a lot of calcinosis or ulceration. Even this morning we see one patient there already. Adult they see less, but then all the other things, including malignancy risk, is more in adult compared to kids. We also make more ANA, anti-nuclear antibodies. Okay. Now, another thing to highlight would be we have less major organ involvement as compared to the adult. Okay. So we run into some muscle disease, but then the more problematic for us would be the skin disease and the vasculitis that we need to tackle. And this is my first patient. You can see the meta rash. So meta rash you can see in rosacea in adult, or lupus, or JDM is one of them. And some of them also span nasolabial fold. And then same thing with that, this active croton papules. And then when you look carefully, you see the dermatomyositis, bushy nail fold capillaries. This is bare eye, and then this you just magnify it. Okay, and then the cotton papules, like in adult, you can have it in any extensor surface, and this is heliotrope. And over here also can have vasculitis, causing ulceration, also causing skin ischemia. Okay, and this is the famous inverse cotton papules, which we usually see in anti-MDA5 antibodies. Okay, this also cotton on the toes, and this patient of mine has vasculitis on the ear pinna. Okay, and nowadays we shy away from doing invasive en bloc muscle biopsy unless you have significant suspicious of other disease. In adult, they probably do it more often because they have more idiopathic inflammatory myopathy, but for kids, I told you JDM is 95%. And what you just asked non-contrast water enhanced series, then you can see all these muscle edema everywhere. Okay, so this is quite typical, and this is from that girl. Now in Pakistan or in India, you can afford to do the whole body, then you can see more. Okay, calcinosis, I just mentioned that it's quite common. Up to a third of patients that has bad skin disease and poor control, you can get calcinosis. We divide calcinosis into many subtypes, depend on the configuration or the figure that you see grossly. But the most common one is still the spot like this, superficial plaque or nodule, usually on the extremities. And then the second most common would be calcinosis circumscripta, where it behaves like a tumor. Quite big one. The one that we see certain time not common would be calcinosis universalis, when the calcium deposit actually at the facial plane or even inside the muscle. So every time when the patient moves, it's quite painful. Okay, and yeah, and then mixed form. So the next few slides is just the picture marathon. Okay, this is one of our patients that has circumscripta. And then when you look at the X-ray, you can see it clearly. At that time, I have ultrasound, so I just ultrasound. And you can see that inside is still liquid. Okay, outside is like a shell of, like shellfish, like a shell heart, but inside is still like a toothpaste. And that area also inflamed. That's why you see the erythematous change over there. Okay, and this is one day it just popped out, and then someone just squeeze it, and then after you squeeze it, just one of the treatment also. But if you treat underlying inflammation, this won't be recur. Okay, so many times actually, if the patient does not have a lot, we send to our surgeon and take them and have them take it out. And this is one of my universalis. You can see that it's on the facial plane. Okay, and this one is abdominal muscle there. And then you see the chest also have it. Okay. So even that patient boy over there, if you look at it, it also has it on the muscle and tendon plane here. Okay. So this is one of the diseases like lupus that serology actually give you the prognosis and alarm you what to do, what to watch for. And this is just to compare to the adult. I just summarize here that the anti-synthetase in kids is quite rare. Okay, it's more in adult. Okay. Anti-MI2 also rare. Okay. The one that identified quite new in the past many years would be the TIP1 gamma, NXP2, and MDA5. We have a lot more in kids compared to the adult, especially in Asia, especially those Japanese. MDA5 is quite a lot. I'll show you the data later. Okay. So these are the clinical correlation. It is quite true with kids and adults is quite the same. If you have TIP1 gamma in adult, you need to look for malignancy. Okay, otherwise they have the worst cutaneous disease, which usually ulcerated. They have all the signs that you can see there. And later on they get lipodystrophy, and treatment is quite recalcitrant. Okay, compared to NXP2, this one is the one that has a lot of calcinosis and bad prominent muscle disease and quite severe. And this one is the one that you see joint contracture a lot. Okay, in adult maybe a little bit cancer risk as compared to TIP1 gamma. MDA5 is famous for mild disease or maybe a myopathic even, but they are more of the rapidly progressive interstitial lung disease, and that would be the cause of death in this patient group. Okay, the skin also bad, but the muscle is not the problem here. Anti-MI2 is a classical JDM where you have bad muscle disease, but it responds to treatment, and after that it responds quite well, and lower risk of ILD, and lower mortalities. And then, as I mentioned, anti-synthetase is more in adults, so I just gonna go. It depends on what amino acid transfer RNA synthetase that you target. So manifestation is a little different. Okay, these are two of the necrotizing myopathy, meaning when you biopsy, you may see less inflammatory cell infiltrate, but what you see is tons of necrotizing muscle that get damaged. Okay, this one usually quite resistant to treatment. Okay, SRP2 and HMGCR in adult is related to the statin treatment, but in kids we don't use statins. Okay, this is the one that usually give you very so many 3,000 or 4,000 of the CK. Okay, and after treatment it does not drop that easy. In Singapore we have actually one of them. Another one is coming my way anyway from Middle Eastern. Okay, and then the only difference is extramuscular manifestation. The SRP2 is a little bit more than the HMG-CR. Okay, now for the associated antibody, meaning it's also present in other diseases like overlap syndrome or lupus. Ro52 is well known to increase risk of ILD if you find in JDM. Okay, so this is in Asia, and this is compared to the adult up here. I just point to you toward the MDA5, as I said, the Asian up to 50% even. And if you look at the Japan somewhere here, it's about a third in pediatrics. Okay, in Singapore we have some, but not as common as that. Okay, so TIP1 gamma NXP2 is more common in kids. Okay, management, I just borrow this from the adult. We do the same thing, early recognition and diagnosis. You just get diagnosis and then you classify organs involvement right away. You don't just look at the skin and the muscle. You want to look at the GI tract, do the water-soluble swallowing study with small bowel follow-through, do the pulmonary function test if they are older than 8, or otherwise just at least check X-ray and the symptom guide you whether you want to do high-resolution CT scan or not. But if you have those antibodies, then you may need to do it, because many times the check X-ray does not pick up the ILD. Okay, and then treat the acute inflammation, and then restore the muscle. So PT, OT always need to be there. Okay, risk for malignancy is not for kids. We don't need to look at that. And then after that, good monitoring. Okay, that is always the key to do. Okay, these are the list of all the medicine we use. In the past, when we don't have anything else, we use a lot of cyclosporin and tacrolimus actually. And in the resource like this, you still can use it. If the main one, for example, methotrexate and MMF is not adequate response, and then you worry. Okay. Now I'm just gonna summarize to you, and this is the European guideline done 2017 actually. up until today is still not different because the biologics for the JDM only rituximab, and that's not even FDA approved for kids use even. Okay, so we are not run into the problem like so many choices like juvenile arthritis. Okay, I just summarize here easy. Okay, when you get a patient with JDM, regardless of what severity, you want to give pulse methylprednisolone, because when the kids, 95% of them will have vasculopathy or vasculitis, and that's reflective of their GI absorption, usually not well. There's a classic study published in Journal of Rheumatology when I was a fellow. You're talking about 40 years ago by Lauren Packman. And she actually looked at the pharmacokinetics of the steroid, taking by mouth and by pulse. And she already show that the oral one does not get absorbed. So you give a lot, it does not work. So we just say you give pulse 3 days, okay, and then you start methotrexate right away. And this classify according to the disease, okay. The presence of severe disease means you have a major organ involvement like cardiopulmonary. Then you don't look at this one. Everything else, for example, skin disease, joint disease, muscle disease, you give pulse methylprednisolone and then you start sub-Q methotrexate up to 1 milligram per kilo. And then if that improves within 3 months, then you keep continue and then you wean the steroid as fast as you can. So normally in our center where we know that the methotrexate start kicking about 2 to 3 months. So in order to prevent so much disfiguring from the steroid use like Cushing appearance, acne or bushy hypertrichosis, kids usually don't like. We use pulse steroid more often and then we drop the daily dose quite fast. That you can get away with it. But for pubertal kids, many times, they don't get stretch mark that you need to worry. In kids, I always teach you the irreversible side effect. That's what you need to worry about steroid use. So one is cataract, one is stretch mark that you can prevent. Another one is a vascular necrosis. The cataract and the vascular necrosis, you need to educate them. And then there's no predictor. You're lucky you get it. So the only thing that you can prevent is the stretch mark by controlling diet. Okay, so during the first 2 months, you are on a lot. So many of them will have moon phase and hypertrichosis, but they may not have a stretch mark if it does not stretch that fast. Okay, if it does not work, then you may need to consider MMF as a second line. You stop the MTX, you start the MMF. Or if you have other, for example, if you have a lot of muscle disease, not much of the skin disease, IVIG is the way to go. So you add IVIG into the methotrexate and steroid and see whether it's work or not. Majority of the time, it's work quite okay. It's a skin disease that we start with. So if MTX not enough and the skin still not under control, then you use MMF. If that's still not enough, I usually go to JAK inhibitor nowadays. Because JAK inhibitor nowadays cost is quite low. And you do the JAK inhibitor that target type 1 interferon. Okay, so tofacitinib is a pan-JAK. If it's work for you, it's work for me. I usually like Loxo or baricitinib. And then it work for me for the skin disease or even some bad muscle disease. You can bypass the anti-TNF if anti-TNF is more expensive. Because otherwise from MMF, then you add anti-TNF. In general, you can combine one conventional and biologic or the targeted synthetics, DMARD. You don't need to use one by one. There's no such a thing because you must use monotherapy. Okay, and newer biologics and JAK inhibitor adverse reaction in kids is quite low. Especially people talk about cardiac insult or hyperlipidemia. I hardly see that. Okay, so yeah, but if you have calcinosis, that difference, you add bisphosphonate. I prefer a short acting rather than long acting. But if you have palmidronate infusion every month, then that's okay also. And if that enhance your adherence, okay. And calcinosis usually take about 2 years before you can see improvement. So you don't need to say that it's not working. And this is for severe disease. I'm talking about cardiopulmonary. Right away, you throw in cyclophosphamide pulse. You don't need to play with the methotrexate, okay? And that usually work, okay? And then if it's work, you just go to the pathway, try to drop your steroid until you stop it. And then everything here If it's inactive disease, you need to ask yourself what indication to use. And that indication would be the indication for you to stop. That one need to be inactive for 12 months minimum. If you scare, then 18 months to 2 years, people do that. Okay, especially the recalcitrant disease that take you long time to get into inactive disease. Okay, otherwise then you go to the experimental. WIM study actually tell you already that rituximab may be used. Okay, I can tell you that in my experience, I hardly need to use rituximab. I actually advocate you to use JAK inhibitor, to be honest. Okay. And then this just mimic the adult, as I mentioned already. Cardiopulmonary, you go to cyclophosphamide. And baricitinib is in the clinical trial. And hopefully FDA will approve. And hopefully that the drug cost will be less. Okay. So amyopathic dermatomyositis. We see this is a group that has very little or no muscle disease, but has bad skin disease. But that skin disease is not that many that has the vasculopathy kind. Okay. And then 26% or almost 25% of them will progress to classic JDM and a little bit more female. ATF onset is a little bit older. And this is what I want to point out. Muscle is normal, muscle enzyme are normal. But they have also less calcinosis because the depth of the skin disease is less. You hardly see ulcer there. Okay. And then obviously malignancy is not there. So it's quite a good prognosis. Okay. And many times you end up using topical actually, and hydroxychloroquine. Okay, now these are all the adverse influence of the outcome. Ulceration of the skin disease start with bad because that's just classify the patient to have a vasculitis. That's not easy to control. Okay, so when you see the ulceration, you have to be really careful. Okay, all the myositis antibody I already mentioned, especially MDA5. Okay, in the past for kids, the mortality cause is actually gut ischemia, gut perforation from gut gangrene. So you have to take it seriously. Okay, when they come in, they don't die from the lung disease in that matter. Okay. So delay in diagnosis, institute, the treatment to delay is not good either, like any of our disease. Now, if you look at 7 to 16 year follow-up, meaning if the adult gonna inherit, this is what you may see. Mainly, almost half of them, you can see some kind of skin scarring or calcinosis or lipodystrophy. Not that many of them gonna get any muscle weakness for you. And then joint contracture in some you may see, not that many, about 1 in 5. 1 in 4. Everything else you don't see much. Okay, so that's not bad. And this is just to tell you that compared to the adult, we have more joint contracture and calcinosis. And this is the treatment. I give bisphosphonates. And then obviously you need to take care of the underlying inflammatory disease quite well. Otherwise, regardless how much you evacuate this calcium, it still keep building up. Okay, and this is 2016. That patient that has circumscripta, 1 year later, you can see that is it less. And then this is 2019 and now 2023. So it takes many years, but it goes away completely, 100%. And this one actually nowadays, when I see him now, he's like 185 centimeters and basketball player. Does not have any drug-free, actually, no drugs. Okay, prognosis, usually they don't die, only 1 to 2%. Okay, and if you look at it, this is the mortality rate. It's quite less than adult, and the cause of death would be your heart and lung disease. Okay, as I said, GI used to be one of the era that we don't know, and then we delay the treatment. So the patient died from sepsis after their gut perforate. Okay, so this is a summary. So I just want to compare to the adult, since we have adult colleagues here. Oops. So JDM is most common. If the patient come to you with myositis, look at the skin, then you will see it. You hardly see other type of IIM. Okay, and the calcinosis, lipodystrophy, and GI cutaneous ulceration is more frequent as compared to the adult. And these 3 antibody is more common than adult. Adult has more anti-synthetase. So before these 3, we hardly send myositis specific antibody, and we also have lower mortality rate as compared to the adult. Okay, and almost half of them quite okay. Okay, and then another thing, 1/3 has monocyclic course, meaning one time and then it's gone. With this, I have 7 minutes, so I will stop here and walk away. Right? Yeah, unless you want to ask question, feel free to do so. And it's a Q&A or not? Not yet.
Thank you for that insightful presentation. We are once again honored to have Dr. Elizabeth Ang back to the stage. She will now be presenting on Kawasaki disease and childhood vasculitides. Please join me in welcoming Dr. Ang to share her valuable insights.
Hi, everyone. While the slides are being set up, I have 30 minutes to go through with you childhood vasculitides. It's going to be a crash course, a whirlwind. But to help me direct it better, can you, by a show of hands, tell me who here are adult rheumatologists? Okay, that's like most of you. Who here are pediatricians? Some. Okay, all right. So can I ask, do the adult rheumatologists look after Kawasaki disease? Probably not, right? Okay, all right. Thank you. And who are the family physicians or general practitioners? Thank you. Do you look after Kawasaki disease? Probably diagnosing them. Yeah. Here are some references. Now, as you know, when we think about systemic vasculitides, everybody goes back to the Chapel Hill Consensus Conference on the classification. And it's quite useful this classification is useful when thinking about childhood vasculitides, but there are some things that are quite special, right? IgA vasculitis and Kawasaki disease, KD, happens mainly in children, and giant cell arteritis at the bottom left doesn't happen in children. So I prefer thinking about childhood vasculitides like this, right? Also in terms of the size of the vessel most frequently involved. And this cartoon is adapted to children. But also in children, there are also vasculitides involving variable vessel sizes, single organ vasculitis, and vasculitis in association with autoinflammatory diseases, which Dr. Tay will cover in the later session. So just again, for the adult rheumatologists, what are the differences in general between kids and adults with vasculitis? Well, it is even more rare in children than in adults, and therefore delay in diagnosis is common. Children overall tend to have more frequent systemic symptoms, but what is less common in children will be the atherosclerotic confounders. Children tend to have different organ involvement patterns. There are unique considerations in choosing therapy with regard to growth, development stages, and fertility. And always the consideration for transition to adult care will come into play when dealing with the adolescent or teenage patient. So why know about it if it's that rare? It is rare, but can be life or organ threatening. Early diagnosis improves outcomes. And some of these vasculitides will relapse or persist into adulthood, or the adult physician may be dealing with the long-term sequelae of these patients. Overall, for the generalist, when do you suspect childhood vasculitis? Again, a child with systemic symptoms, fatigue, fevers, and especially failure to gain weight or growth delay. Sometimes these children are thought of as lazy, not wanting to move so much, right? Tired easily. And of course, as a vasculitis, think about the symptoms related to end organ ischemia or damage. And also, if a child presents with multi-system involvement, childhood vasculitis must be at the back of your mind. The general approach is the same as most rheumatologic conditions. Take a meticulous history, a comprehensive physical exam. And if I could, put as a signboard, exclude mimics. Because childhood vasculitis is rare, if you're thinking about it, one of the first things to come to your mind is this a mimic of a childhood vasculitis? And I will elaborate on this in the next slide. So what are the common or important mimics of vasculitis? At the top row, infection, infection, infection. Probably even more so here in Pakistan than in Singapore. And you might be more well-versed in this than I am. Other mimics would be malignancy, autoinflammatory diseases, again, lupus, JDM, IBD, MCTD, drugs, toxins, heritable diseases, vasospastic diseases. I leave this here for your reference, and I think it would be more useful if I went in a little bit into detail per the disease. So let's go on a whirlwind tour through childhood vasculitides, okay? Kawasaki disease. This is considered a medium vessel vasculitis with a predilection for coronary arteries. It is one of the rare rheumatologic or inflammatory conditions where males are more affected than females. And outcomes can still be poor despite IVIG treatment. Like in all rheumatologic conditions, early treatment helps in the long-term prognosis. In terms of treatment, I would say the take-home message for KD would be treat it aggressively, aim for 0 fever, 0 CRP. I think most in the room are familiar with the diagnostic criteria for KD. This is from the AHA, American Heart Association, namely fever persisting for 5 days or more, plus 4 out of 5 of the following mucocutaneous features as listed in this slide. Now, I want to say that among these 5 mucocutaneous features, some are going to be more common than others. For example, conjunctival injection, lips and oral cavity changes. Thank you so much. And cervical are the most common. The rash in KD is also very common and tends to be polymorphous. Unlike the beautiful slides that Liang showed you, the rash in KD can look like any rash. The edema of the hands and feet are quite characteristic. For example, if you can see in this slide, this little boy looked like he placed his feet into a shallow pool of red water. If you see edema or erythema, bright erythema of the palms and soles, think hard about KD. In KD, there are signs that are not part of the diagnostic criteria, but are still important. BCGitis, helpful to regions like Pakistan and Singapore because BCG are universal for our babies. If you see that in a child with a fever, KD must be top on the differential. Perineal desquamation, it seems to be common, and especially from reports out of India. Extreme irritability, sterile pyuria, hydrops of the gallbladder. This graph here shows that the criteria, the mucocutaneous criteria for KD can happen at different times. And depending on which point you see the child, some of those criteria may only be available on history. In order to not miss a diagnosis, even if the child does not have a rash, ask for that symptom from the parent in order to not miss the diagnosis. Another important point in diagnosis is to remember that the presence of an intercurrent or proven infection does not rule out KD. Both infection and KD can happen at the same time. Now, in reality, without treatment, the fever and the mucocutaneous signs will disappear. But the importance of treatment is because that the blood vessel inflammation can result in long-term damage, particularly to the coronary arteries. And because it is a medium vessel vasculitis, in severe cases, other medium vessels may be involved as well. In fact, it is now well known that sometimes the first presentation of polyarthritis nodosa may look like a KD, which speaks again to the spectrum of this medium vessel vasculitis. Again, I want to highlight the importance of early treatment. Although by criteria, the fever must be for 5 days, at least 5 days, treatment can begin before 5 days if you, the diagnostician, are quite certain based on the presence of other more pathognomonic features. Also important to note that a normal cardiac ultrasound does not rule out KD. This is the AHA algorithm for assessment of a child with KD, which I think most in the room are familiar with, so I will skip this. I do want to also say that there are some specific instances of KDs that are easy to miss. Firstly, the node first KD. This may look like a child with mumps, retropharyngeal abscess, treatment-resistant bacterial lymphadenitis. Sometimes the clue, if possible, is to get an ultrasound, in which case you will see multiple cervical lymph nodes rather than one cervical lymph node, which is the case in bacterial lymphadenitis. Sometimes KD may appear incomplete, and this means that the child does not satisfy all or 4 of the criteria for KD. This is especially the case in a very young child, and I want us to think about incomplete KD in an infant with prolonged fever and other less pathognomonic signs like aseptic meningitis. Finally, the term atypical KD refers to infants or children who have some features of KD, but some features that are less usual. For example, the kid with KD shock, sometimes called Kawasaki. These patients may be in the ICU presenting as culture-negative shock or viral myocarditis. In these cases, please think about KD so that treatment can be given early. What is the treatment? IVIG 2 grams per kilo is still well known for it is still standard of care. Aspirin at the dose of 30 to 50 milligrams. In the past, it was thought that 80 to 100 milligrams per kilo per day is useful, but I think there is increasing evidence that lower doses may be used during the febrile period. Now, in the last 10 to 12 years, there is a lot of discussion on which of the KD kids should get steroids and when this should be used. This could be a whole lecture on its own, but thankfully I will not be going into that. If it is helpful, referring to the European guidelines on when to use steroids in KD, these are the patients that they have highlighted that should receive steroids in addition to IVIG at the outset. Those from item 2 to 5, okay? So steroids should be given, of course, in consideration for those who are IVIG resistant, but definitely those who have features of HLH, features of shock, the young child, or the child who at the outset presents with coronary or peripheral aneurysms. The scores coming out of the US suggest that a Z score of more than 2.5 at presentation is a marker for a poor prognosis, and these are patients in whom you might want to give steroids at the outset. The other term for this would be primary intensification of therapy. The definition of refractory KD is failure of resolution of systemic inflammation within 48 hours of primary treatment. Some will say within 36 hours from the end of the first IVIG treatment. Now, again, there is very little strong evidence to suggest what the second line treatment should be. I think it is generally standard of care in most institutions in the world to give a second dose of IVIG, plus minus steroids in the refractory cases. But again, there are no strong randomized controlled trials to really prove that this is the case. And I believe in speaking to Dr. Tash and myself, we differ somewhat in the way we would approach this. I think from your point of view, the important thing is to recognize that treatment of the inflammation should be aggressive and as complete as possible. And options for therapy besides IV and IG and steroids then include infliximab, anakinra, or cyclosporin. In other countries in the world, cyclophosphamide is also an extremely important and good therapy for those who may not respond to the second dose of IVIG and steroids. Let's move on to another PED-specific systemic vasculitis, IgA vasculitis, which most of us still call HSP. This is the most common vasculitis of childhood, more common than KD. And as you know, only 10% or less happen in adults. I believe you're familiar with the IgA vasculitis classification criteria, and these were validated for children in 2008 and is as follows. I want to highlight other complications in IgA vasculitis, namely urogenital, CNS, and lungs. Though they are uncommon, they can happen and should prompt you, the clinician, to think about more aggressive therapy. Because in reality, most children just need supportive treatment, but steroids should be considered when other organs are involved, namely orchitis, cerebral vasculitis, pulmonary hemorrhage, and severe GI involvement. In such cases, the considerations for treatment would be prednisolone 1 to 2 milligrams per kilo per day, or even pulse solumedrol doses. As in all cases of rheumatology, organ or life-threatening involvement will necessitate stronger cytotoxic immunosuppressants. Now, again, there are guidelines out there for IgA vasculitis or HSP, but these pertain mainly to HSP nephritis. If I could just share one pointer, since the HSP nephritis can manifest after the initial phase of the purpura and petechiae, regular urine analysis for at least 6 months after disease onset is recommended, even in the absence of a rash. I want to share some anecdotal thoughts on IgA GI involvement. This seems to be a common problem in the countries in Asia, but there are no studies and no good data and no guidelines to guide the management in these cases. And that's important for us in the Asia Pacific because this is not uncommon. These patients often present with severe abdominal pain and or rectal bleeding, hematochezia. In these cases, steroid treatment can be considered to reduce the intensity and duration of abdominal pain in as early as possible. And I would anecdotally recommend doses as per the previous slides. In these patients, don't forget supportive treatment in the form of gastric protection, nasogastric decompression, parenteral nutrition, and antibiotics. Of course, exclude intersusception with an ultrasound or even a perforated gut in the child who looks like they're presenting with an acute abdomen. Nevertheless, IgA vasculitis ischemia of the gut alone can look like an acute abdomen. All right, let's move on to the small vessel vasculitis, ANCA-associated vasculitis. Now, the diagnosis, in summary, you can think of it as they have a positive ANCA and clinical features. Just as Liang mentioned for the diagnosis of lupus, don't use classification criteria alone for diagnosis. With regard to ANCA testing, ELISA is more reliable than immunofluorescence. I'm sharing with you some practical pointers. And ANCA levels alone are not a reliable indicator of disease activity. Histo or biopsies are desirable, but should not delay the start of treatment in patients in whom you suspect ANCA-associated vasculitis and have organ or life-threatening disease. All right, for GPA, here there are pediatric validated classification criteria, and they are as follows: upper airway involvement, laryngotracheal bronchial stenosis, pulmonary involvement, renal involvement, ANCA positivity, and a histopathology. In this case, usually it's of the kidneys or the respiratory tract. For MPA, there are no classification or diagnostic criteria, so even in pediatrics, we fall back on the Chapel Hill nomenclature or a description. MPA should be thought of in any patient with necrotizing small vessel vasculitis. And just like GPA, this is another pulmonary renal syndrome. So any child presenting with a pulmonary renal syndrome, ANCA-associated vasculitis, is on the list of differentials. Of the three ANCA-associated vasculitis, I think EGPA, formerly known as Church-Strauss, is the least common. And if you are considering the disease, first consider the mimics, namely parasitic infection, hypereosinophilic syndrome, which could be primary or secondary. What are the differences between childhood and adult AAV? This slide is a summary of the two available studies comparing childhood and adult onset AAV. Children tend to have more fevers, whereas adults have more myalgias and peripheral neuropathy. Children tend to have more ischemic abdominal pain and nasal cartilage damage in the GPA subtype of AAV. They also, in one study, tend to have more upper airway involvement in the form of subglottic stenosis and alveolar hemorrhage. Really, children can present with more severe disease. Also in the form of higher relapse rates, more damage, and therefore a longer duration of therapy. The treatment of GPA or MPA really depends on whether they're organing or life-threatening manifestations, and I hope that I've shown you that in children, there very often are. What would you consider potentially organ of life-threatening? These would be when there is symptom involvement of the systems on the left. It is interesting in this paper that they write that nasal or paranasal disease is not ultimately organ or life-threatening as long as there is no bony involvement or cartilage collapse. But practically speaking, how do you know? And practically speaking, do you want to wait until this happens before you treat aggressively? So I would like to encourage us to just consider the nose as an organ too, and that because damage can be so debilitating, treat nasal involvement as if it was organ threatening. Okay? Now, it is beyond the scope of this talk to discuss the specific treatments of childhood onset small vessel vasculitis. And I'm happy to say that there are guidelines out there, or I should say consensus-based recommendations from Europe looking at childhood onset versions of these conditions. If I had to give a summary, in general, induction therapy would be steroids plus MMF, or steroids plus cyclophosphamide, or steroids plus rituximab. In fact, there's increasing evidence that steroids plus rituximab can be standard of care. Maintenance can be in the form of rituximab, azathioprine, or methotrexate. And in patients with GPA, Bactrim or cotrimoxazole is often used in the prevention of both infection as well as relapses. The outcome of AAV really varies depending on the studies you look at, but the thing that we are most afraid of would be renal failure and the knee and chronic kidney disease. What do you think the next thing I'm going to talk about is? It's going to be polyarthritis nodosa. Here are the criteria for thinking about polyarthritis nodosa. Like in many cases of vasculitis, biopsy is necessary, but because PAN is a medium vessel vasculitis, sometimes angiographic abnormalities may be enough to clue you into the diagnosis. Plus one out of the following 5. Skin involvement, myalgia or muscle tenderness, hypertension, peripheral neuropathy, and renal involvement. Just like in AAV, children don't often have the peripheral neuropathy, but when a child presents with such, the consideration for PAN and or AAV should come up. Now, children tend to have PAN in the cutaneous form, meaning they have severe skin lesions without systemic inflammation or major organ involvement. Again, the treatment of this should be individualized. Occasionally, NSAIDs and or steroid treatment alone may be enough, and then careful monitoring for systemic inflammation. Anecdotally, I will also share that in the PAN, looking for a trigger like a previous streptococcal infection is very important in such patients. Here is a one-slide summary on the treatment for PAN. Induction, so for a lot of the vasculitides, induction with steroids plus cyclophosphamide or MMF, and maintenance. Unlike AAV, rituximab is less used, rather azathioprine, methotrexate, and MMF. In a child-specific trial, MyPan, they did show that MMF was probably similar and as efficacious and less toxic than cyclophosphamide in children with PAN. So I think this is a reasonable treatment. I think finally, Takayasu arteritis, again, a large vessel vasculitis, and therefore imaging is vital to the treatment, to the diagnosis and the monitoring of such patients. I want to again compare for the adult rheumatologists here, the difference between childhood and adult Takayasu arteritis. Again, children tend to have more frequent constitutional features like fever, weight loss. And that really requires you as a clinician to think about it when a patient comes with just very non-specific symptoms. Unfortunately, children also tend to have more sinister features like cardiomyopathy, presenting as arrhythmias, heart failure, sometimes an elevated serum creatinine, abdominal pain. We think of Takayasu as the pulseless disease, but the absence of these pulses is a less common finding in children than in adults. As I mentioned earlier, sometimes the first presentation of Takayasu arteritis may be a refractory KD. In a study or a description by Dr. Tash's group, looking at 23 patients with Takayasu, 8 of them, which is about a third, presented as refractory KD. So for the KD kid who does not settle inflammation, follow them up and consider imaging for Takayasu arteritis. I think the rheumatologists here know that in the early stage, acute phase reactants are elevated, but normal acute phase reactants like FBC, CRP do not exclude the diagnosis. What are the mimics that should be excluded for Takayasu? Syphilis, more relevant to the adult, but for the child, tuberculosis. I think I will skip this portion about imaging or algorithm in pediatric large vessel vasculitis, but I leave it here for reference. The point to make is that besides imaging the aorta and its branches, because Takayasu can also cause problems in the brain and in the heart, where you can aspire for standard of care, image these vessels as well. Okay? Here is a summary statement on the treatment of large vessel vasculitis, induction with steroids plus MTX, anti-TNF, anti-IL-6. It is beyond this talk to decide which is the best treatment. Okay? All right. Finally, just a few slides on vasculitis involving variable vessel sizes, namely Behçet's. This is important because about 5 to 10% of patients with Behçet's start in childhood. Those of you, the adult rheumatologists here, will know that the symptoms are of recurrent oral and or genital ulcers, skin lesions, and uveitis. If the child has very early onset symptoms of Behçet's, consider mimics, namely inflammatory bowel disease, monogenic conditions like haploinsufficiency of 20, and these should come into the consideration. Single organ vasculitis, thankfully, is rare in children, and the one that I wanted to highlight would be primary angiitis of the CNS, namely a child who has vasculitis causing CNS symptoms with no other organ involvement. I think Dr. Tay will be covering this topic in the talk after tea, so I will not go into the vasculitis associated with monogenic or autoinflammatory conditions. If I had to summarize vasculitis in 3 points, I hope that what you will remember is that kids get systemic vasculitides too, and treatment is available, and early treatment saves lives and organs. For the rheumatologists in this room, if I could just correct some myths and pearls about vasculitis in the young. A lot of times, with regard to classification, we refer to adult classification criteria. And there are even fewer trials in children, but there are trials, and we do have information on what could be best. The strongest evidence base is for KD and IVIG as the first line of therapy. There are emerging trials for other vasculitides, and I hope you've been able to see that there are guidelines for pediatric vasculitis from 2019. In small vessel vasculitis, there have been a few trials. The PEPPERS trial showing rituximab for AAV that included children. The MyCYC, again showing that MMF is not inferior to CYC for ANCA-associated vasculitis. And again, I highlight the SHARE guidelines for IgA vasculitis, HSP. There are pediatric trials for PAN, namely, or pediatric patients involved in trials, namely MyPan, again showing MMF is not inferior to cyclophosphamide. There are SHARE guidelines also for Takayasu arteritis, and I think this is where I will leave this whirlwind or crash course on systemic vasculitis and welcome any specific questions later. Thank you very much.
I I just want to say because time कम था इसलिए टी ब्रेक का हमने ये किया है कि आप लोगों को कप्स में पेपर कप्स में कॉफ़ी और चाय सर्व हो जाएगी by where you are sitting because we are just continuing with the course so that we finish in time. ठीक है?
Thank you, Dr. Ang. That was an exceptional presentation. We'll now move on to the Q&A segment of this session. I'd like to request our chairpersons to please moderate the discussion.
Thank you very much. It was a pleasure to listen to all the presentations. I express my sincere gratitude to all the speakers for their outstanding presentation. Now the questions, there are few questions to different speakers. The first question is from Dr. Ziauddin, and this has been addressed to Professor Tash. Any difference in treatment of calcinosis of juvenile dermatomyositis and systemic sclerosis in children?
I would say no for kids. Yeah. It's still the same. We still use bisphosphonate. Yep. So my answer is no. Unless anyone else has any idea. Yeah. For systemic sclerosis and for JDM. For calcinosis. Yeah. Same.
Another question is from Dr. Fazaila. How does the disease phenotype in monogenic differ from the other types? Either the skin or the hematological are common, and what are the red flags of monogenic lupus?
So for monogenic lupus, the onset is really much younger than what we would expect for sporadic lupus, especially in the younger than 5 age group. And because of the type 1 interferonopathies, a lot of the features may also not have that classical immune complex deposition. They have also a lot of failure to thrive, recurrent infections, and I think the key to really diagnosing that monogenic lupus is through genetics, because without a genetic test, it's really difficult to say that it is due to a single gene mutation. Yeah, so some of the key red flags would be if you have a patient with failure to thrive, recurrent infection, and it's just very refractory to your standard of treatment for systemic lupus, then, and in a very young age group, you would want to think about monogenic lupus.
The continuation of the same question of monogenic lupus, how can we differentiate sometimes struck up with autoinflammatory fever syndromes with monogenic lupus? Is there any markers?
Yeah, so monogenic lupus in general will still behave a little bit like the systemic lupus. So in terms of the disease attack, their CRP may not be very high, as opposed to the classical systemic autoinflammatory condition where they tend to have very high inflammatory markers during the attacks. Doing the ANA is also really helpful in helping to differentiate between monogenic lupus, because they would still produce that anti-nuclear antibody, as opposed to many other systemic autoinflammatory conditions that do not have a positive ANA. Of course, as with a lot of systemic autoinflammatory disease, they also have very characteristic organ manifestations as well as fever pattern. So some of these will be easier classified, which I will mention later in the talk on autoinflammation.
Summary, if we can say that in the monogenic lupus, the presentation is different from the autoinflammatory, which has specific organ involvement. Plus, anti-nuclear antibodies are very in a high titers.
Yeah, that's right.
Now, another question addressed to Dr. Liang, and this is asked by Professor Tahseen Naseem. Can you discuss how type 1 interferon pathways contribute differently in monogenic versus classical lupus?
It's almost the same in terms of the pathogenesis, but it's just that the pathogenesis in terms of monogenic is really due to a gene mutation that causes intrinsic activation of that interferon 1, as opposed to systemic lupus where it is multiple factors coming together that cause production of type 1 interferon, but also a lot of activation of autoreactive lymphocytes resulting in antibody production. So type 1 interferon is a key player in both monogenic as well as the sporadic systemic lupus. It's just that in monogenic, it is due to a single gene mutation that results in that activation.
So the effect will be the same?
Yeah.
Another question which has been addressed to Professor Tash, and Dr. Zahid Khan has asked this question: how do you distinguish juvenile dermatomyositis from limb girdle dystrophy? This is more of a pediatrician question. Or metabolic myopathies where CK is mildly elevated. So differentiation between juvenile dermatomyositis and limb girdle muscular dystrophies or metabolic myopathies where there will be proximal muscle involvement.
Yeah, I didn't know that I have 7 minutes left. Otherwise, I would go to myositis mimic or differential. Metabolics, well, the pattern for our JDM, like any other inflammatory myositis, usually proximal muscle involvement and symmetrical. Those limb girdle or any other Becker muscular dystrophy, they have their own pattern of the weakness. Number one, or certain phenotype. For example, Duchenne in boys, you have hypertrophy of your gastrocnemius, that kind of things. Both of them will have elevated muscle enzymes. MRI would not change either. It's just a distribution. And if you really still cannot, then you do biopsy. But another clue would be the skin manifestation. JDM, 95% will have some skin. At least you have to learn how to look at the nail folds, capillaries, and those dystrophies should not have at all. Okay? Yep. And then another thing would be ANA. I didn't stress that much. 50 to 70% will have ANA positive, but your muscular dystrophy should not. So there are many things that you can look at before you end up with a biopsy and do the spatial stain or genetic study for those mutation. Yeah.
I think this, as the organizers, they're running short of time, so this is the last question. This has been asked by Dr. Saira, who is postgraduate resident at Fatima Memorial Hospital. FFH? Fatima Memorial Hospital? FFH. Fauji Foundation. So, MMF in ANCA vasculitis, isn't it inferior to cyclophosphamide due to its higher relapse rate, especially considering adult guidelines? The question has been addressed to Dr. Elizabeth.
Question about whether MMF is inferior to cyclophosphamide for ANCA-associated vasculitis. Induction. Sorry? Yeah, I think that was shown in one adult study where they differentiated between the MPO positive and those without MPO. But I think for children, what we know is that you can consider them equal.
Thank you to our speakers and the audience for this engaging exchange. Now, I would like to request Professor Samina Ghaznavi, Dr. Javed Malik, and Professor Samaira Farman Raja to present a token of appreciation to our honorable chairs, Professor Dr. Tahir Masood and Dr. Samia Naz.
Dr. Samaira, I would like to say on my behalf, thanks from all the University of Child Health Sciences to invite us and to the organizer for organizing such an enlightening session on pediatric rheumatology. Thank you so much.
Professor Dr. Tahir Masood.
Just a few words. As I said, like in adult rheumatology, we've tried to, lead for pediatric rheumatology. In pediatrics, Professor Tahir Masood probably was the one who led, and now Dr. Samia is taking that on.
I think I must extend my greatest appreciation for Dr. Samaira and the other team members who have organized this session on pediatric rheumatology, and this has been very, very useful session, and we owe a lot to Dr. Samaira and other colleagues from adult rheumatology, because they are the ones who actually have laid the foundation for the pediatric rheumatology. Pediatric rheumatology started just from an outdoor basis area where we used to see the patients, but with their help, we have extended that to indoor, and now the facilities at the University of Child Health Sciences are such that these patients are being looked after very well, and so we owe a lot to these people. Pediatric rheumatology these patients are not very uncommon, and pediatric rheumatology is just at the stage of infancy. But I think the will is there, so with passage of time, we would be able to have a specialty training in pediatric rheumatology, and ultimately, obviously, with any postgraduate program, the specialty would develop, and there is a need for pediatric rheumatologists for this country. So, inshallah, more and more pediatric rheumatologists would be produced, and these patients would no more be missed and would be diagnosed earlier for better outcome. Thank you very much.
Professor Dr. Samia Nas.
Listening to all the speakers, I have concluded one sentence. Kids are not young adults. And rheumatological condition in children are more severe as compared to adults. आज की तीनों presentations का ये conclude था. Thank you so much.
Thank you. With that, we conclude the second segment.